Okay, so now we are going to talk about how to interpret a spinal fluid, right? So you have an 8-month-old child that is coming in with possible meningitis, and you do a spinal tap on that patient to assess their spinal fluid to see if they have meningitis. And now we're going to talk about how to interpret some of the numbers. So when you do a spinal tap, the initial things you typically will send the fluid for is going to be a WBC count, a red cell count, a glucose level, and a protein level. So let's do an example. So let's say this child coming in has fever, lethargy, and you're concerned about meningitis. So you do a spinal tap on this 8-month-old. So you do the spinal tap, and the results come back as 100 white cells, 40,000 red cells. The glucose comes back at 35, which is low, and the protein comes back at 95, which is high. Okay, so now let's interpret these numbers. So the first question is, based on these numbers, does this child have meningitis? Many people would probably say, yes, this child has meningitis. The question also is, how the 100 white cells that you have, first of all, what's the normal white cell count in the CSF? Are you allowed to have any white cells in your CSF as normal? And there's a magic number that you have to consider, right? And what is that magic number? That if you have more than this many white cells, that is abnormal and worrisome about meningitis, right? Which means you're allowed to have some white cells in your CSF as normal. So what is that number? The number is 5. So if you have more than 5 white cells in your CSF, then that is abnormal, okay? You can have up to 5 as normal. So this child has 100 white cells, 40,000 red cells, a glucose that is low at 35, and a protein that is high at 95. So initially when you look at this, you would say this child has meningitis. I would say that this child actually does not have meningitis, right? And why does this child not have meningitis? When you look at this, there's a reason when you look at this that you can say this child does not have meningitis. And it is related to the red cell count. The fact that there's a lot of red cells means that it was a traumatic tap, and you introduced red cells into the CSF as part of the tap, but also you introduced white cells into the CSF as part of the tap. So the question then is, can you account for the number of white cells that you have in your spinal tap compared to the number of red cells that you introduced, right? So can you account for that? And you can. So you can do a ratio. So let's do our ratio of red cells to white cells. So our ratio here is 40,000 red cells and 100 white cells, which is 400 to 1. That is our ratio of red cells to white cells in this spinal fluid. This is a normal ratio of red cells to white cells in your spinal fluid. So this is a normal ratio of your red cells to white cells. 400 to 1 is normal. How do I know that's normal? Because I'm going to compare the CSF ratio to the ratio in the serum, in the blood, right? So in the serum, let's do a ratio. Typically, the number of RBCs, when you get a CBC, you can look at the RBCs in that CBC. So what's the typical number of RBCs that you would have in your CBC as normal? Most people don't look at that, right? Everyone looks at the hemoglobin, the hematocrit, the MCV, the RDW. Nobody looks at the RBC count, right? So the RBC count in a CBC as normal would be actually about 4 million red cells per ml. And then when you got your CBC, you get your white count. What's a normal middle average white count in a CBC? Maybe about 10,000. So what's our ratio? 400 to 1. So our ratio is 400 to 1 in the serum. If your ratio in your CSF is less than that in the serum, you have too many white cells per red cell, and that is abnormal and consistent with meningitis. If your CSF ratio is equal to that of the serum, or if your CSF ratio is greater than that in the serum, you have accounted for all of the white cells based on the red cells that you introduced, right? But again, if your CSF ratio is less than that in your serum, you have too many white cells per red cell, and that is abnormal, consistent with meningitis. Okay, so that's something to consider as you are interpreting this. So now the next question is, if we've accounted for all the white cells based on the red cells, and we say this kid does not have meningitis, why is the glucose low at 35 and the protein high at 95 in this child who now we are claiming does not have meningitis because we've accounted for the white cells per red cell, right? So let's talk about the glucose first. The glucose is coming up at 35, right? And typically with meningitis, bacterial meningitis, your glucose is low and your protein is high. So why is this child glucose low if we think this kid does not have meningitis? What's the typical ratio of your CSF glucose to your serum glucose? It's about 1/2 to 2/3. So this child's glucose of 35 in the CSF, if we check the sugar in the blood, if his glucose in the blood was, let's say, maybe 70, because he's not eating that much from the meningitis and vomiting and things, and his serum glucose is 70, and his CSF glucose is 35, that actually is the ratio you would expect, right? It's being flagged as low because the laboratory normal value is maybe 40 or 45, so the lab is flagging it in red and saying it's low, but in reality this is not low for this child because the serum glucose is 70 and this 35 is based on that. So that's an important thing to consider as well. Then the next question is then, why is a protein elevated at 95? Again, if this child does not have meningitis, because you worry about elevated protein suggestive of meningitis. So the protein is high for what reason? Because it's a traumatic tap. When you did the traumatic tap, you introduce red cells, you introduce white cells, and you introduce everything else that's in the serum. Albumin, immunoglobulins, other proteins. So the protein is falsely elevated because of the traumatic tap then. And it's just flagged as high just because, again, that's out of the normal reference range of the lab, but it's not necessarily high because of an infection like meningitis. It's high from the traumatic tap. Okay, so that's how you would interpret these numbers to look at this patient and then say this patient likely does not have meningitis. Okay, you would still then send this. You would still send a blood culture on this child and start the child on empiric antibiotics while you are waiting for the culture results. So this is supplemental information that you're going to use initially. It doesn't rule out the meningitis, but it's helpful information to help you decide could they have meningitis or not then. Okay, so that's how you interpret the CSF on this type of a child. So now the question is, how do you know that these 40,000 red cells in the spinal fluid is from a traumatic tap and this kid actually does not have an intracranial hemorrhage causing these 40,000 red cells to be in the spinal fluid, right? How do you know it was traumatic? These 40,000 red cells are from the traumatic tap versus the child presented with lethargy and vomiting and a bulging fontanelle. And how do you know this kid does not actually have blood in the spinal fluid and intracranial hemorrhage from trauma or a spontaneous bleed causing these 40,000 red cells to be present? So the way you would do that is there's two ways to help determine that. One is at the bedside as you are doing the spinal tap. When you do a spinal tap, you typically get 4 tubes of of spinal fluid. You have 4 tubes of spinal fluid. The first tube, you will go through the skin and into the spinal fluid. If it's a traumatic tap, the first tube will have the most blood. And then, as the spinal fluid flows and you collect 1 cc of spinal fluid in the following tubes, because of the flow of the spinal fluid, the red cells should be diluted out. And as you're looking at the tubes, you should see the bloody tap become more clear and the spinal fluid become more clear with your second tube and your third tube, and by your fourth tube, it should be almost clear, right? Because you went through a blood vessel in the skin as you entered into the spinal fluid, and that's what caused the bloody tap and the traumatic tap. So the first tube will have the most blood, and that should clear up with subsequent tubes. If the child actually had blood in the spinal fluid from an intracranial hemorrhage, those tubes should not clear up. You should continue to see blood in each of the tubes because you have blood in the spinal fluid. So at the bedside, as you're doing the procedure, if it's just a traumatic tap, each tube should get more clear and less red as you collect more spinal fluid. That's one way to determine as you do the procedure whether this is a traumatic tap and these red cells in the blood is from that, or whether it's actually blood in the spinal fluid. The second way is going to be related to after you collect the specimen and you send it down to the lab is going to then report the color or appearance of the spinal fluid. When they give you the results, they're going to give you the color or appearance. And there's a word that the lab will use that then can help you determine that if it was a traumatic tap or if it was actually blood in the spinal fluid. What is that word that the lab will use to describe the color of the spinal fluid? They'll use the word of xanthochromia, X-A-N-T-O, xanthochromia, right? And xanthochromia means that there's a yellowish tinge to the spinal fluid and the supernatant. When they spin it down, there's a yellowish tinge to the spinal fluid supernatant as they process the fluid. And that yellowish tinge implies release of bilirubin from hemolysis from red cells, meaning that the blood was sitting there long enough to allow for hemolysis and release of bilirubin. So if you have xanthochromia present and you see the color as reported as xanthochromia, that implies that it's old blood that has been in the spinal fluid, old enough to allow the red cells to lyse and to release hemoglobin, so that would go along with potentially an intracranial hemorrhage and blood in the spinal fluid. When you did the tap, and if it was a traumatic tap and you just introduced a red cell as part of the procedure, you should not see xanthochromia when the lab reports the color. There's usually not enough time for the red cells to do that. Now sometimes you can have xanthochromia for other reasons. You could have a false xanthochromia reading as well, because sometimes the red cells and the specimen maybe it's not processed in time and it sits in the lab on the counter for a long time, or somehow the tube was shaking a little bit and the red cells that were in the spinal fluid caused some lysis, and that movement caused some lysis and release of bilirubin. So sometimes you can get a false positive xanthochromia, but in the pure sense, you should not have xanthochromia with a traumatic tap. And if you do have xanthochromia, then that implies old blood that has lysed and potentially an intracranial hemorrhage. So I think that's something to consider as well. Okay. Now I want to talk about, let's say you do a spinal tap. Let's erase some of this here and talk about if you do a spinal tap on a patient, and let's say you are only able to get 1 drop of spinal fluid from your spinal tap, right? You do the tap, and for whatever reason, you get 1 drop of spinal fluid. Which one test are you going to send that 1 drop of spinal fluid for, right? If you got 1 drop of spinal fluid, which one test will you send that drop of spinal fluid for? So if you think about it, the one test that you need to send that 1 drop of spinal fluid for is actually a culture, right? So if you said white cell or something else, that can give you supplemental information, but ultimately you want to send the spinal fluid, that 1 drop, for a culture, because you want to rule out bacterial meningitis. And the only way to rule out bacterial meningitis is to do the gold standard testing for that, and that is going to be a culture. So you send that 1 drop of spinal fluid for culture to rule out a bacterial meningitis. Now, a lot of hospitals now have PCR testing. So if you have the capability of doing PCR testing on the spinal fluid, potentially you could send it for PCR, and that could be as sensitive as culture. But the gold standard to diagnose bacterial meningitis is a culture. But if you are able to do a bacterial PCR on that fluid, depending on the sensitivity of the test that you might have available, this could be just as good as sending a culture. But the point is that you don't want to send 1 drop of spinal fluid for anything else that is just giving you peripheral information, but you want to send it for some gold standard to rule out bacterial meningitis. So if you get 1 drop of spinal fluid and you worry about bacterial meningitis, send it for a culture. And the same thing applies for any bodily fluid. If you're worried about a bacterial infection in any type of fluid and you get 1 drop of fluid, you need to send that for culture. Don't send it for anything else, right? So if you're worried about a UTI, do not send 1 drop of urine for anything else, right? Don't try to put it on your urine dipstick and try to look for, Leukocyte esterase and nitrites and things like that, right? The 1 drop of urine, you send it for culture. 1 drop of blood, you send it for culture. 1 drop of pleural fluid, send it for culture. If you're worried about a bacterial process, you got to send that specimen for culture. All this other information is extra information that can help you potentially decide if it is bacterial or not, but the gold standard, you want to send it for a test that is a gold standard to check for a bacterial process, and a CSF culture would be the way to do that then. Okay, so now I want to move on to another example, right? So let's say you do the spinal tap on this 8-month-old with fever and lethargy, possible meningitis, and now you do the tap, and the numbers come back with 100 white cells. Now the red cells are only 4,000, so you've gotten better at the tap, so it's not as traumatic, so that's good. Glucose is still low at 35, and protein is still high at 95. And now the lab also tells you that of the white cells, there are 90% that are neutrophils, and 10% of these are lymphocytes. Okay, so the first question is, does this child have meningitis? If you do the ratio, it's going to be 40 to 1. Red cells to white cells in the CSF, the ratio is 40 to 1, so that's very low. No matter what the ratio is in the blood, based on your CBC, this is going to be way below that. So this child definitely has meningitis, based on the fact that the ratio is 40 to 1, very low. So too many white cells per red cell, right? So this child definitely has meningitis. So now the question is, does this child have bacterial meningitis, or does this child have viral meningitis? The 90% neutrophils would suggest that this child has bacterial meningitis. But I will say to you that this child actually does not have bacterial meningitis. This child likely has viral meningitis, early viral meningitis. When you have an early viral infection, you can have a predominance of neutrophils in that early viral infection. The body responds by creating bands and neutrophils with any type of infection, including viral infection. So early viral infections will give you a predominance of neutrophils. And then later on, as the viral infection progresses, then you would probably have a predominance of lymphocytes. So this is a nice picture for early viral meningitis. 100 white cells is a common number, or a number that we will commonly see with viral meningitis. If a child has bacterial meningitis, these numbers are going to be very, very impressive, meaning that the white cell count in the CSF for bacterial meningitis is going to be very, very high, like thousands of white cells, okay? 100 white cells in the CSF is more consistent with a viral meningitis. So if this kid had bacterial meningitis, then this should be thousands, 3, 4, 5,000 white cells. In bacterial meningitis, the red cell count depends on the tap. The glucose in bacterial meningitis is going to be very, very low. This is consistent with likely a viral meningitis. With true bacterial meningitis, your glucose is going to be really, really low, like almost zero, like single digit low, because the bacteria are eating up that glucose in the CSF then. So your glucose is going to be very, very low and very impressive. Not is it half to 2/3 of the serum or anything like that. It's going to be really, really low, almost zero as a value. Protein in bacterial meningitis is going to be very, very high, right? Not a little bit high, is it a traumatic tap, and can you explain the protein that way? This is going to be very high, like 300, 400, 500 of a value when you have true bacterial meningitis. So these are very, very impressive numbers that you would see with bacterial meningitis. These numbers are more consistent with a viral meningitis. The 100 white cells is typical of a viral meningitis, and then a little low glucose, a little high protein goes on with the viral meningitis. And this is the predominance of neutrophils is more likely consistent with an early viral meningitis at this point for this type of a patient. Then, okay. So again, it's going to be very, very impressive numbers at this point. Then, so okay. All right. So and now I want to shift gears a little bit and talk about different age group and how we would approach that child. So let's change this to maybe let's change the age to a young baby. Okay, let's change this age to maybe a 2-week-old, right? So hopefully you can see that, right? It's a 2-week-old coming in with fever and maybe lethargy and possible meningitis. So you have a newborn, right? So let's change that age again to 2 weeks of age, and see how we would approach that patient, right? So a 2-week-old, okay? So now you do the spinal tap on this patient, and the numbers come back at white cell of 20, red cell of 50, glucose of 45, and protein of 60, okay? So now the first question is, does this child have meningitis? 20 white cells, more than the 5, right, that we talked about earlier. So this is consistent with possible meningitis. You can't really do the ratio here with RBCs to WBCs. It's like 5 to 2 or something. The ratio is typically used when you have thousands of red cells. So in this situation, you can't use a ratio and correct for it then, okay? So it's 20 white cells, 50 red cells, glucose is kind of normal of 45, protein is kind of normal of 60. So the 20 is more than the 5 white cells that we talked about earlier, so potentially consistent with meningitis, right? So actually, this kid doesn't necessarily have meningitis, because this 20 white cells in the CSF can actually be normal in the newborn period. So if you look at a graph in the first 30 days of life, and you look at the number of white cells in your CSF, most literature says you can have up to 30 white cells in your CSF in the first month of life. And by around 30 days or 1 month of age, that's when you should have less than the 5 white cells. Because the blood-brain barrier is not that well intact in the newborn period, you might have extra white cells in your spinal fluid as normal. So again, most literature supports that you can have up to 30 white cells as normal. I draw the line kind of squiggly because it's not a linear relationship. You can't say on day 16 of life they should have 12 white cells as normal, right? All you can say is in the first 30 days of life, you can have up to 30 white cells as normal in your CSF, and after 30 days, you should be down to less than 5 white cells, okay? So this child, 2 weeks of age, coming in with possible meningitis, you do the tap, and you have 20 white cells. That puts the child somewhere right in the middle of the graph, showing that this could be a normal white cell count for this child, okay? So then the question is, okay, maybe this is normal, but maybe it's not. Maybe the child does have meningitis, right? So if this child, based on the spinal fluid, were to have meningitis, what would be the most likely cause of this child's meningitis? It would not be group B strep. It would not be E. coli, right? Because we said bacterial meningitis would give you a very impressive number, right? Thousands of white cells, very impressive numbers, right? So this kid does not have bacterial meningitis. Most likely this child has viral meningitis. So what would be the cause of this child's viral meningitis? You might think it's enterovirus, but it's not actually. The most likely cause of this child's viral meningitis is going to be herpes. This is a CSF consistent with herpes meningoencephalitis. So herpes can give you something called a hemorrhagic meningoencephalitis. So the 50 white cells is actually typically found in the hemorrhagic meningoencephalitis that can be caused by herpes. So these 50 white cells are part of the infectious process. And the 20 white cells is a typical CSF count in an infection caused by herpes. So this is a CSF count and numbers possibly consistent with herpes meningoencephalitis, okay? So if a child is coming with fever and lethargy or seizures, and especially if they have like skin lesions or mom has some sort of history, then you really got to think about herpes as a cause of meningoencephalitis in this type of patient. And why is it so important to think about herpes as a cause of meningitis in this age group and in this type of patient? because it's the one viral meningitis you have to treat, right? If it's enteroviral meningitis, it doesn't matter. They're going to get better anyway, right? But you have to first think about the possibility of herpes as a cause of meningitis in this child, so then you can think about whether you have to start the acyclovir, right? If you don't think about herpes as a cause, you're not going to start the acyclovir. So first you have to look at this and say, oh, based on the history, based on the age, based on the numbers, could this child have herpes meningoencephalitis? And then if you say yes, it's possible, then you need to empirically start acyclovir on that patient, right? Then that can really reduce morbidity and mortality. And then the next thing you have to do is, if you start the acyclovir, you have to make sure you've sent the spinal fluid for a herpes PCR, right? Because you need to know, does the child really have herpes, and can you stop the acyclovir, right? Because let's say 2 days from now, if you don't have a herpes PCR sent off on the CSF, and 2 days from now you start acyclovir, and then a couple days later the child looks great and is looking better, you don't know if that kid is getting better because they actually had enterovirus and were going to get better anyway, or did they actually have herpes and the acyclovir was treating it. So you need to make sure that you send the herpes PCR off of the CSF, so when it comes back negative, then you know it's safe to stop the acyclovir. So if you're going to start acyclovir on a child, then you have to make sure you have a definitive test available to know when to stop the acyclovir. Otherwise, you're going to be obligated to give 10 days or 14 days of acyclovir at that point. So I think that's a major consideration to think about in this type of a child. So that kind of summarizes how to approach a newborn and interpret a newborn and their CSF findings in that age group. So for this last scenario, I want to go back to our original age child of an 8-month-old coming in with possible meningitis. Okay, so let me give you a different kind of case scenario, or a little vignette. Okay, so there's an 8-month-old child that is seen in the outpatient clinic a couple of days ago, and they were seen for fever, had some viral upper respiratory type of symptoms, and were looked at and determined to have an otitis media, an ear infection, and was started on amoxicillin. Okay, so 8-month-old with fever and otitis media started amoxicillin, and then the child goes home, and 2 days later calls back to the clinic and talks to a nurse, and the mom calls back and says to the nurse that, my baby's been taking this amoxicillin for the last couple of days, but now, just seems to be more fussy, more irritable, maybe more lethargic and, vomiting. So she's worried about possible meningitis. So the nurse says, yeah, you know what, this could be meningitis, so we need to have you go to the emergency room to be evaluated. So the child goes to the emergency room and is seen there, and there's concern for meningitis. So in the emergency room, the child has a spinal tap, and they are able to get 1 drop of spinal fluid from that child. So what do we send that 1 drop of spinal fluid for? We send it for culture, right? So we send that spinal fluid for culture, and the child is admitted to the hospital. It started on IV antibiotics, IV ceftriaxone, and 2 days after being in the hospital, the child is looking better, is not having any more fevers. The culture after 48 hours comes back negative on the spinal fluid. So the child is, the antibiotics are stopped, the child is sent home, and then a couple days later shows up back in the emergency room with full-blown meningitis. So the question is, how did we miss the full-blown meningitis on the child? How did we miss that diagnosis? So if you think about the history that was given, the history was that this was a child that was already on antibiotics when the spinal tap was taken, right? The child was diagnosed with otitis media, was given amoxicillin, took 2 days of amoxicillin, and then presented with a complication of the otitis media spreading into a possible meningitis. And when we did the spinal fluid at that point, the child was already on antibiotics, and then when we did the culture, then we have to recognize that the culture is no longer reliable in that type of a scenario, in that type of a setting. If somebody has already been on antibiotics, then the culture might come back negative and be a false negative because the antibiotics might have sterilized the culture, right? So this child was admitted, had the culture, was started on IV ceftriaxone, actually got better because was responding to the ceftriaxone that we were treating for the bacterial meningitis, and then the culture came back negative. We had to recognize that the culture was a false negative, and that child, we cannot rule out bacterial meningitis on that child based on the culture because he was already on antibiotics. And in that scenario that I said, the culture was negative after 48 hours, the child looked good, so was sent home on no antibiotics, but they came back a couple days later with full-blown meningitis. So basically when a child is on antibiotics and you do a culture, you have to realize that the culture is negative, it could be falsely negative at that point because of that patient. And this patient actually had a partially treated bacterial meningitis that needed a full course of antibiotics. So now the question is then, if a child's on antibiotics and you know the culture is not reliable, what can you do to help rule out bacterial meningitis, right? So you get that one drop of spinal fluid, right? So you send it for culture, it was negative. So, but you know it's not reliable. So what are your options? So you have a couple of different options. So you can redo the spinal tap. And you can go to the parents and say, you know, we want to redo the spinal tap because we want to get more fluid to do some more testing. And if you get more fluid, then you can send it more for the numbers and try to interpret those numbers. If you repeat the spinal tap and the child has 0 white cells in that spinal fluid, that child does not have meningitis and never had meningitis, because it takes weeks for a white cell count in the CSF to normalize. So a couple days of IV ceftriaxone will not cause the white cell count to come back to normal, come back down to 0. So if you repeated the spinal tap at that point and they had 0 white cells, does not have meningitis, never had meningitis. But if they have more than 5 white cells on that spinal fluid, you're stuck, because that's abnormal and that child can have partially treated bacterial meningitis. So you can repeat the tap and hope you get 0 white cells on the tap and you're done. The kid doesn't have meningitis, never had meningitis. You can repeat the tap and then also send it for a PCR, right? And you can send it for various bacteria. Many times if the culture is negative, the PCR will still remain positive after a couple days of antibiotics. So if it comes back positive, then you know there was a bacteria there. Or if the PCR maybe comes back positive for a viral process, like enterovirus, if the PCR and the CSF comes back positive for enterovirus, then more likely that child has a viral meningitis and does not actually have a bacterial meningitis. So that can help you sometimes as well. Now sometimes you go back to the parents and you say, I need to redo the spinal tap so we can get some more fluid and try to get some more numbers, and the parents want nothing to do with it. They say, you know, you tried multiple times, it was traumatic, it was bloody, you got 1 drop, I'm not letting you do another spinal tap on my child. And I've had that happen to me. And then I just basically tell the parents, well, I cannot rule out bacterial meningitis in your child, so I need to keep your child here in the hospital for IV antibiotics for the next 10 to 14 days. So I keep them in the hospital for a prolonged course of antibiotics, because I don't know if they have a partially treated bacterial meningitis. I don't have more fluid to rule that out, so I'm going to be cautious and I'm going to keep them in the hospital for a prolonged course, a full course of IV antibiotics. And I've had parents say to me, that's fine, no problem, we're going to stay here, I don't want the tap. Other parents will say, okay, well, I'll give you 1 try because I don't want to necessarily have to be here for 14 days, so you get 1 shot at it, and hopefully you get the spinal tap and you get the numbers and you get the fluid, and then you can do some interpretation based on that as well. So that's an approach to a child who has already been on even oral antibiotics like amoxicillin for something else, and now you're worried about bacterial meningitis, and what do you do in that situation? How do you interpret the culture? That's how you would kind of interpret the culture and use the supplementary information to help guide your treatment, or potentially you might just treat them for a presumptive bacterial meningitis and give them a full course of antibiotics at that time. So with that, I want to wrap up the discussion about meningitis. So hopefully that was informative and educational. How to interpret CSF, how to interpret the numbers, different organisms, different antibiotics you would use, and how you approach these type of children. So we look forward to seeing you as part of the next CRASH case. And with that, we'll end this session and look forward to seeing you with the next one.